To this case presented for an 18-year-old female with an ankle sprain 6 weeks ago. The students note several findings, and we'll go through this very challenging case together. We've loaded it up already with collective minds. This is an 18-year-old with ankle pain. The sprain was 6 weeks ago. When we're evaluating these cases, we want to understand how to make a checklist approach so that we can make sure to see all of the features of the case. In going through our soft tissue structures, of course, we're going to go through our medial, lateral, and extensor tendons, noticing that we have hypertrophic PT tendinosis and some mild tenosynovitis, some mild insertional PT tendinosis. We can see that also on coronal imaging. We'll be looking in this region. These images are slightly blurry and thick, so we underestimate the amount of tendinosis that's occurring there. Moving past the medial flexor tendons, we're going to take a look at our flexor retinaculum and the region of our tarsal tunnel to appreciate whether or not we have any compressive masses in this location. We can see now, let's move to our lateral flexor tendons. We'll again look at the axial images. What I'm looking at on the brevis and longus, the brevis being medialized, has a low-lying peroneus brevis or an accessory cordis. The brevis inframalleolar along the inferior perineal tubercle has a split tendinosis extending to the base of the fifth metatarsal, where there is also some tendinitis seen there. Let's just make this a little smaller and see that over here. So we're looking at the region of the brevis here with its split and small amount of tendinitis at its attachment. The longus, as it moves past the perineal tubercle, we're seeing poor definition in that location. There is some tendinosis that I can see better on the axial images. Let's just get this windowed a little bit better for us. Okay, great. So we can see that that longus is slightly larger and has tendinosis proximal to the cuboid tunnel. No tendon subluxation, superior perineal retinaculum intact. Notice that we have this accessory small little muscle that's joining from the region of where the posterior crural fascia joins the region of our posterior ligament complex. We have this small accessory muscle that joins the quadratus plantae. Moving on to the extensor tendons, we can appreciate the intact extensor tendons and the anterior tarsal tunnel and deep peroneal nerve. Moving on to ligaments that we can see in this case, the syndesmosis intact, the interosseous ligament intact. We can appreciate the ATFL, this high-grade partial tear. We can see the gap on the fibular side. Let me zoom in on this for a second. We can appreciate its non-displaced tug injury or avulsion at the anterior aspect of the tip of the lateral malleolus. That's your ATFL, high-grade partial tear. And we are also seeing some synovitis looking for the calcaneofibular ligament now. We can see that often better in coronal images. We can see the tip as it attaches on the lateral malleolar tip. We can see a portion here, and then we are losing it in this location because of the thick slice of those images, and we can see it better over here. Again, let's pick up the dorsal aspect of that calcaneofibular ligament here. Moving on to my posterior talofibular ligament, we're going to see that here. What I like to do is compare that to my axial T1 weighted image just to make sure that the fat is relatively clean. If it's a large degree of synovitis, I may suggest that this patient has posterior ankle impingement. So we have now moved on from that. Let's get back to our deltoid ligament and our medial ligament complex. Let's appreciate the sprain of that posterior deep deltoid with its interstitial edema. The superficial deltoid, I can see a portion of the tibial spring. Again, these are thick slices, so I want to look at that again axially. I can see some of my flexor retinaculum here as it attaches to my adductor hallucis. The region of my supromedial band of spring ligament as it attaches here. And then we're moving along the medial talar head to the medial plantar and inferior plantar bands. Just noticing as you stop here the facetted nature of this talus. That's not the normal configuration, but we'll get back to that. Let's go back to our deltoid ligament here, appreciating the sprain of the posterior deep deltoid, appreciating the superficial deltoid seen here. Let's window that a little bit better. And the anteromedial band here, we can see our tibiospring ligament sprain in this location as it gets down to the spring ligament. This is the supromedial band. The supromedial band of the spring ligament has real estate. Anteriorly, the band of the anterior superficial deltoid, that tibionavicula band goes here. The tibiospring, as we mentioned, is really the workhorse to me. It goes centrally along the medial neck. And then, of course, we have our tibiocalcaneal band here, poorly seen, but still intact. And then these medial plantar bands, we can see them partially here. Let's move this down again. We can see them partially in this location, but we can also appreciate them on the coronal images as sprayed with the synovitis seen in this location with this facetted nature. Now let's move to the ropes. The Achilles, appreciating that the soleus is stopping or inserting in the myotendinous junction above the level of the tibio-talar articulation, otherwise it would be low-lying and may predispose to claudication. The insertion is intact. Notice that we have some trace retrocalcaneal bursitis, and I've drawn a line here just showing us the Haglund bump in this patient who does not have the full syndrome that I can see of Haglund syndrome, but I can imagine a world that they do have some amount of Achilles tendinitis. Plantar fascia, I'm looking at periaponeurotic edema, looking at the central cord. I also like to look at it on T1 weighted images, because I can often see nodules of plantar fibromatosis more easily in that. So moving on to discuss the bony features of this case, what we can appreciate is that we have this anterolateral talar dome osteochondral contusion with no fluid undermining the fragment or bed. We have some chondral thinning along the dorsal aspect. I would say that this is a grade 1 osteochondral contusion at the anterolateral dome. I can also see some patchy cystic change, perhaps some mild edema where the dorsal talonavicular ligament attaches. When we're thinking about determining how to measure angles on the MRI, some angles that have been used to measure talk about the hindfoot alignment angle where they bisect the tibial axis and then they compare that to the medial calcaneal wall. So they go to the sustentaculum talus, go to the posterior aspect, draw a tangent along the medial calcaneal wall and compare that to an angle of the distal tibia. And that is an angle that's been mentioned in AJR for the extra-articular lateral hindfoot. This is a wonderful article by Dr. Donovan and Zahava Rosenberg, and it goes through all of the features that we can see in patients who suffer from lateral hindfoot impingement, in that we can see that at the talocalcaneal impingement, the subfibular impingements that occur, and they give you an access to understanding how we would avoid or how we measure the angles to avoid this lateral hindfoot impingement. And this is the bisection of the tibia along the medial wall. And anything greater than 6 degrees is abnormal. One of the more complicated ways to measure hindfoot varus that has been shown to have reduced interobserver variability is something called the sustentacular tangent. Again, you're going to take the bisection of the tibia. You're going to identify the point of the medial point of the sustentaculum talus. You go to the posterior aspect of the calcaneus and get to the medial wall of the heel, and you compare this line of the mid-tibial axis to the medial tangent points or the sustentaculum tangent point. And when we look at the diagnostic performance of how those angles work, the most accurate measurement that has been found in a patient who has valgus is going to be that medial calcaneal contour. And it's going to have a sensitivity, it's going to pick it up in approximately 86%, depending on where you put your cutoff. And they found that the most accurate measurement of varus is the sustentaculum tangent, reaching a specificity and sensitivity of 91%, or 71% if you use less than 12 degrees of valgus. So looking at the different ways to measure it, I think, can be difficult, and I don't tend to use measurements. I tend to use what is going on inside of the case to understand the biomechanical features. What I see in some of these patients that is of interest is, in this case, one of the most useful things that I will use is the relationship of Meary's line. For me, using the talus and the first metatarsal axis is one of the most important things to determine whether I have a cavus or a planus, since that is something that, if I can see it in the sagittal plane, that is often present in these cases. The next thing I want to understand is how my navicula covers my cuboid. So that's another thing that I can tell to understand what my angles are. So just looking at the coverage of the cuboid, I want to understand the entire articular length of that surface, drop a line where my navicula is, and then I can understand to what degree I'm actually bisecting that. 50%, if I'm greater than 50% covered, that's a case of planus. If I'm less than 50% covered, this can be a system of cavus. So here we have an elevated first Meary's line. We have a decreased cubonavicular coverage angle. And in terms of the hindfoot valgus or varus, one clue I see is that the talonavicular offset is occurring. So this tells me that this foot tends to supinate. That means that when they hit the hindfoot and the calcaneus glides forward on the talus, there's a certain amount of pressure between the talus and navicula. And what is happening here, perhaps because of restricted range of motion, possibly at this functional fibrous coalition, is that we are able to have greater motion on that lateral aspect of the talonavicular joint, and then we can affect our pronated moment. So when we heel strike in this patient, because of the restricted range of motion that's potentially occurring in this location from the functional fibrous coalition, as evidenced by some of the soft tissue abnormalities that are overworking in this area, we can appreciate that we then have to have a strong pronated moment. And those patients, now, what I think about when I think about does this patient have varus or valgus, what I think about is that this patient has a slight hindfoot valgus relative to what would have been the normal compensatory mechanism of this person's cavus. And that is the reason why it seems to be difficult to measure, because I think that on one side of the articulation, on the lateral side, we have this offset and then it normalizes medially. So we have supination occurring, but where is it occurring? So when we think about looking back to now about that talar head and the facetting that's occurring and the increased pressure that the talus is focused on the navicula and the sprains of the spring ligament, what I see here is that when the foot heel strikes, it has to go through supination to get towards that first metatarsal, but it's actually declinating and overworking at the talonavicular articulation. So in my opinion, I would not be mentioning about the varus or valgus nature of this hindfoot. I would probably focus on the fact that this is a subtle pes cavus variant and that there's pes cavus features and that the abnormal biomechanics, the instability that I see that's affecting is at the talonavicular joint where there's osteochondral contusions. And what happened at the level of the sprain and this acute injury on top of this person's biomechanic is indeed consistent with a Weber A supination adduction injury, so that the foot was in a supinated position and the forces that came in were adducting the foot. So abduction would be away, the forces came in. So I imagine as this person tried to had an episode of instability moving from that heel strike to the pronated phase of gait through that anterior talofibular ligament sprain and that osteochondral defect. So this is a very complicated case, and I think the reason why it gets complicated is because there are features of trying to measure these types of angles that can be variable depending on a variety of different features of the talonavicular articulations. One last point that I think makes it even more complicated when they're not the classic versions of your pes cavovarus or your pes planovalgus is understanding the attitude of the calcaneus. One more confounding feature that I see in all of these angles is the relative attitude, whether this is a neutralized calcaneal attitude or it has a echinus attitude or a calcaneal attitude which is dorsally flexed. So altogether, this is a case, I believe, of pes cavus with I guess we would say hindfoot valgus because it's uncompensated varus, where we didn't make enough varus to complete the biomechanical smoothness of this, where we can see that we have offset of our talonavicular articulation. So I think that this case is a little too subtle and sensitive to fall within the bounds of something that I can teach reliably to you. But I think the observations to take home in this case are to notice that when we have a developmental variation, you can have curvature of your articular surfaces, probably in preservation of some of the ankle motion that the developmentally is occurring as the skeleton ages. The curvature of spaces is known as a ball and socket angle. So when we see curvature where we're going to suspect that there is some kind of developmental variant, we're going to search for our coalitions and understand that those patients may present with non-healing ankle sprains because of their already uncompensated biomechanic. Notice in this patient also this very atypical muscle that is rounding from the posterior crural fascia to the quadratus plantae, another cute feature that supports that there are developmental variations in this patient. So thanks again for this case.